So finally, we reach the group of cardiovascular drugs that a majority of your patients, whether you're on the internal medicine service or on surgery, will be on: beta blockers. You can easily remember them because they all end in O, L, O, L. To understand when to use a drug, you need to understand the pathology of the condition you're intending to treat, which organs the receptors are located on, and the potential side effects related to excessive block or undesired effects, because other organs may have these receptors as well. First, let's discuss the beta-1 receptors that are found on the myocytes and the beta-2 receptors found in the peripheral smooth muscle vasculature. So beta-1, myocardium; beta-2, vascular smooth muscle cell. Look at this slide. It looks super familiar because we already know it. Let's review beta-1 adrenergic stimulation one more time. So, you stimulate the beta receptor with epi or norepi, cause activation of GS. We stimulate adenylyl cyclase. We increase levels of cyclic AMP and make the regulatory subunit of protein kinase A come off. Protein kinase A is now able to phosphorylate the L-type calcium channels on the sarcolemmal membrane, allowing an influx of calcium, which leads to calcium-induced calcium release, because that calcium that flows across these L-type calcium channels binds the ryanidine receptor, causing a conformational change of this ryanidine receptor on the sarcoendoplasmic reticulum, releasing calcium into the cytosol. Another way that protein kinase A works is that it phosphorylates phospholamban, which is the inhibitory protein on the sarcolemmal membrane that normally inhibits SERCA, or sarcoendoplasmic reticulum calcium ATPase, from pumping calcium into the SR for further use. If you put a phosphate on there, this protein is unable to inhibit SERCA, and you get a great amount of calcium for future storage. So we're putting calcium into the cell, and then we're also going to store it for future contractions. Stimulation of beta-1 receptors of pacemaker cells within the specialized conduction system. Remember, the specialized conduction system refers to the tracts of neuromyofibrils from the SA node to the Purkinje system. So the stimulation of beta-1 receptors of these pacemaker cells increases the opening of the cyclic nucleotide gated ion channels responsible for the inward depolarization, which is the funny current, and it also opens L-type calcium channels that are responsible for the slow inward calcium current near the end of phase 4. So this is how some of the side effects of bradycardia, AV block, and congestive heart failure can occur. If you decrease the ability of the specialized conduction system, aka anything from the SA node to the Purkinje system, to depolarize, then you can decrease the heart rate, causing a bradycardia. You can even potentially depress the conductance to the point where you get AV block, where there's no conducting through the AV node, or you can suppress the entire conduction system where there's no depolarization, and you get acute congestive heart failure, where you have just accumulated blood in your heart and you can't send it anywhere except backwards. So basically, quick summary: beta-1 adrenergic stimulation of the heart gives us increased contractility, which is termed inotropy, increased heart rate, which is termed chronotropy. The same thing occurs in beta-2 adrenergic stimulation that occurs in vascular smooth muscle cells, where we get an increase in the G stimulatory cascade, which will eventually lead to the activation of adenylyl cyclase to increase the amount of intracellular cyclic AMP, and eventually liberating protein kinase A. Remember, this is beta-2. The key difference between beta-1 and beta-2 is that beta-1 is in the myocardium, beta-2 are on vascular smooth muscle cells, and that vascular smooth muscle cells use a different method for contraction. They do not use the troponin tropomyosin complex. Flashback to the mechanism of smooth muscle contraction, in which increased levels of intracellular calcium will bind to calmodulin, and this calcium-calmodulin complex will activate myosin light chain kinase. Now, the stimulation of myosin light chain kinase will phosphorylate the myosin heads so that we have enough ATP to load our myosin head in the conformation required for the power stroke. So how does beta-2 adrenergic receptor stimulation cause smooth muscle cell relaxation if we know that beta adrenergic signaling causes an increase in cyclic AMP and causes an increase in contraction when we're talking about beta 1, not beta 2 receptors. So in the case of beta 2 receptors, that is vascular smooth muscle cell, let me write that up here again, just so that we are always having a reference point. So in the case of beta 2 adrenergic stimulation, we have increased cyclic AMP to liberate protein kinase A, and it will phosphorylate myosin light chain kinase. When myosin light chain kinase is phosphorylated, it is not able to facilitate the contractile process, and vascular smooth muscle cells will relax. And that is a very important understanding, because vascular smooth muscle cells are particularly prominent within the bronchioles. So for example, if you give someone a beta blocker, you have the positive effects that you would want in the heart, such as decreasing inotropy and contractility, but then you also block the beta 2 receptors if you're using a non-specific beta blocker in someone's bronchioles, and you can cause them to have bronchial vasospasm, and that can really be damaging for someone that has asthma. And it's all because they have different mechanisms of contracting. All this signaling is the same in the vascular smooth muscle cell and in the cardiomyocytes. But at the end, the cardiomyocytes use the troponin tropomyosin complex, while vascular smooth muscle cells use calcium calmodulin myosin light chain kinase. So the antagonism of beta 2 receptors in places like the lungs and coronary arteries can be particularly bad for a COPD or asthma patient or someone suffering from Prince-Meadows angina. Again, beta 1 is in the heart, and then beta 2 is in vascular smooth muscle cell in very important places like the coronary arteries and the lungs. You need stimulation of beta 2 receptors for vasodilation. If you block them, you get vasoconstriction. Beta 2 adrenergic blockade is not good for anyone that has COPD or asthma, because those bronchioles are already destroyed in COPD and hypersensitive and inflamed in asthma. The last thing you want to do is block the ability of that smooth muscle to relax and open up those airways. In the case of Prince-Meadows angina, which is characterized by coronary artery vasospasm, it would be a top-notch, terrible idea to inhibit the ability of the coronary artery vascular smooth muscle cells from relaxing, because we already have too much vasoconstriction limiting blood flow to our myocardium to begin with, particularly because they have atherosclerosis. What are some other side effects associated with these drugs? Some that might be particularly high yield and important are impotence, sedation, and sleep alterations. So no one likes their sex or sleep-wake cycles messed with. And if your patients have these side effects, you can guarantee they will not take the medication. For a male to achieve and maintain an erection, you need to increase blood flow to what chamber in the penis? The corpora cavernosa and the corpus spongiosa, or spongiosum. If you are taking beta blockers that antagonize beta 2 receptors on the vascular smooth muscle cells that provide blood flow to these corpora, you prevent blood flow to these penile tissues. Because if you block the beta 2 receptors, you cause vasoconstriction, because the vascular smooth muscle cells will be stimulated to constrict, and you decrease blood flow to the penile tissues. What do you think is going to happen to your patient? Well, I can tell you what's not going to happen to your patient. They will be suffering from erectile dysfunction, and they will be very unhappy, which is also called impotence, but no one ever says that. So for the sedation and sleep alteration component, I just like to think about it as block of the beta adrenergic component of the reticular activating system that keeps us alert and is responsible for slow wave sleep. So reticular activating system and then slow wave sleep. If you block the reticular activating system and block the ability for us to have slow wave sleep, you have a sedative like effect, and you mess with their sleep, so you get alterations in sleep-wake cycles. The same situation can be said for the I'm talking incredibly high-yield concept, in which a beta blocker can mask the signs of hypoglycemia. Now why is that? Well, when someone's hypoglycemic, they will be acting rather impaired, and the brain will respond by activating the sympathetic nervous system, which means we'll be stimulating beta receptors. So let's look at this diagram. Remember that when we release catecholamines, because we activate the sympathetic nervous system, we release things like epinephrine and norepinephrine into the circulation. You bind beta receptors on hepatocytes and stimulate glycolysis. in glycogenolysis and gluconeogenesis because we want to increase glucose available for our muscle and brain. But in the patient that is on a beta blocker, they have a medication that is not only antagonizing the response, but is hiding some of the other manifestations of having low blood sugar. So not only do we exacerbate the hypoglycemia by preventing the elevation of blood sugar levels by blocking these compensatory mechanisms, but we also block the outflow of the sympathetic nervous system that shows us symptoms such as tremor, anxiety, nervousness, an increase in heart rate or tachycardia, palpitations, mydriasis, pallor, and coldness. And a lot of these things should make sense to you because they are directly associated with sympathetic nervous system outflow. You get vasoconstriction of the skin, and that is why people feel cold when you touch them. Pallor, because the vasoconstriction shunts blood away from the skin surface, and you get less of the redden effect that is provided by oxygenated blood in the capillaries of the skin. Mydriasis is from stimulation of the pupillary dilator muscle, which is dependent on sympathetic nervous stimulation. The heart rate and the palpitations are due to beta 1 stimulation of the heart, and the tremor, anxiety, and nervousness are also directly related to sympathetic nervous system-like effects. And you can mask all these if you're giving someone agents that block the receptors that mediate these manifestations of hypoglycemia. So glucagon is a great way to counteract this and also treat an overdose because it is a potent stimulator of glycogenolysis and gluconeogenesis. Glucagon also activates G protein receptors in the heart, which causes activation of adenylyl cyclase and an increase in cyclic AMP. This causes the sarcoplasmic reticulum to release its calcium stores, and as a result, there is an increase in SA node activity. Two specific beta blockers that you have to know because they have very unique toxicities are metoprolol and propranolol. Metoprolol is metabolized in the liver, so it can actually interrupt normal lipid metabolism, and a lot of times you'll be tested on your ability to remember that metoprolol inhibits the metabolism of lipids in the hepatocytes and can cause dyslipidemia, while propranolol is classic for exacerbating vasospasm, particularly in Prince-Metal angina, because it is a non-specific or non-selective beta blocker, so it blocks beta 1 that's in the heart, and it blocks beta 2 that is within the vascular smooth muscle component of our coronary arteries. And again, in Prince-Metal angina, we're having vasospasm. We need those arteries to relax. We don't need to cause them to vasoconstrict even more. Remember, beta 2 receptors, vascular smooth muscle cells, if you block them, you prevent relaxation, which is the actual pathophysiology behind Prince-Metal angina. Another unique consideration is the cocaine addict. Classic board question. People love asking about cocaine, probably because people love doing cocaine. Cocaine can induce coronary artery vasospasm, just like Prince-Metal angina. You should never start someone that you suspect a cocaine overdose, because if you block beta 1 and beta 2 receptors, you block this component of vasodilation, so you get more vasoconstriction. And then, why is that significant? Well, cocaine also stimulates alpha receptors, and alpha receptors are already causing vasoconstriction because they're being stimulated by that cocaine. So the combination of inhibited vasorelaxation causing vasoconstriction because we're blocking beta 2 because we gave them a beta blocker, and then the cocaine is stimulating the alpha receptors is going to cause absolutely ridiculous blood pressures.